We have a 67-year-old female with no comorbidities. In April 2021, she presented with abdominal pain for about a month. 2 weeks later, she had obstructive jaundice and cholangitis. On admission, the labs showed a total bilirubin of 9 milligrams per deciliter and a direct bilirubin of 8. The ultrasound showed biliary obstruction at the distal end of the CBD, dilated pancreatic duct, and chronic calcular cholecystitis. In May 2021, an ERCP was done, and it showed a distal CBD stricture. Intrahepatic biliary radicals were dilated, and a plastic stent was inserted with good drainage. The triphasic CT showed intrahepatic biliary radicals that were dilated again, and then pancreatic duct was about 1 centimeter. In June, there was obstructive jaundice, so a ERCP was performed, and it showed a migrated stent that was replaced, and there was a distal CBD stricture as well. EUS FNA showed benign mucinous pancreatic tumor. The multidisciplinary team met and decided to go ahead with palliative treatment for the patient, as the patient was not fit for surgery. In August, the patient had an attack of acute severe cholangitis with sepsis. The ERCP showed a migrated plastic stent with failed removal, and another insertion of an uncovered metallic stent was done. Today we're going to do an ERCP with SpyGlass for retrieval of migrated stent, and now we'll go to room 1 with Dr. Hany Shehab and Dr. Ahmed Altonbary as well.
Hello, good morning everyone. Pleasure to be with you all. I have here my colleague, my friend, Dr. Ahmed Altonbary. We were with him a few minutes ago, and my lovely assistant, Salma. So this lady, she has the problem of a proximally migrated plastic stent. I did an ERCP for her a couple of weeks ago. It was very difficult to extract the stent, which has deeply migrated inwards. This lady, she has a mucinous pancreatic neoplasm, benign neoplasm. So the aim was just to palliate this lady. But of course, we need to extract this migrated stent to avoid the risk of recurrent cholangitis again. So what I did in the last ERCP is that I put an expandable metallic stent, both to palliate the obstruction definitely, and to facilitate my entry and the extraction of the plastic stent today. So if you see the endoscopic view now, we already have our SpyGlass passing through the metal stent. Of course, this facilitates the entry very much. And if you look at the SpyGlass view, we have now passed the metallic stent. Of course, there is one drawback to having a metallic stent inside, is that the water that you are injecting, a lot of it is falling into the duodenum.
What device that you plan to remove stent? What device? What accessory?
Well, we're glad that we have the new accessory of the SpyGlass. It's the Spy basket that I will show you right now, and you can see here this is the stent. It seems to be into the right hepatic duct, coming down from the right hepatic duct. Here we have close to the hilum. I hope you can see the fluoroscopic view too. Fluoro, Asha?
Yes.
Okay. So yes, we see it in front of us. So I tried last time using an extraction balloon, throw a forceps blindly. It didn't work. So now we're going to try this new accessory, which is the Spy basket.
I think Spy now explain why balloon and extraction traditional didn't succeed.
Yes.
Because the stent migrated just right to the right hepatic duct, and we have the angle of the stent angle or attach it to part of the hilum, so it's difficult to extract with the balloon, and this is the advantage of SpyGlass. We have previously also reported cases of retrieving migrated stents, either pancreatic or biliary.
Open. So this is the basket. It's open. Of course, it seems easier for me just to hold the flap. I don't think it's the best option, but I think this is the easiest right now, so we'll give it a try. So close, Salma. Yes. Yes. Close, close. So I'll pull back the Spy altogether. Now the problem, as you see, that it's abutting against the other wall. So this is the main problem, and this is why we failed to extract it previously. Screen. So there is also the problem that this stent has been migrated for a long time. Screen.
Yes, it may be attached inside.
So let's hope it's not deeply attached to, embedded in the tissues inside.
How long you place uncouple stent, metric stent, how long?
It is a 6 centimeter stent because it was a very short distal stricture.
Can you describe what you are doing?
Yes.
Are you only pulling the stent, or are you also moving the scope?
So I am holding two things. I'm holding the spy itself, and I'm holding the forceps, and I'm pulling both simultaneously. Because when I pull the spy only, the basket stays inside. Screen. Now the problem is that the stent also abuts against the edge of the metallic stent now, as you see on the screen on the fluoroscopy. So I don't want to pull more. I think now.
Right?
Yes, because I think
On the
that.
floor, the stent moving.
Yes.
Yes.
But yes, so as you can see with my hands, I'm holding both together. It's a bit more difficult than doing it
This
with.
manipulation is two doctors may be compared to one doctor, what different?
I think the challenge here is to pass the upper part of the stent
Of the metallic stent,
without
yes.
being impacted against the metal stent, which is a difficult part.
The metallic stent is actually collapsing a little bit against it. So I'll try to go inside again and come out in a better position.
Different direction. Yes.
Yes, so as you see, this is the edge that holds against the edge of the metallic stent.
I think we can see the edge also in the endoscopy.
So now,
Yes.
so I think now it should be coming a little bit better.
Yes, I think we passed inside the stent now.
So I'm pushing my endoscope a little bit inside to get more in the longer position, to be more in line.
I think maybe if we are a little bit impacted, even at this moment we can leave the flap of the stent and try to hold the stent itself. But I think we passed already.
I think we're passing. If you look fluoroscopically, we're moving well.
Yes, we are coming to the edge. Yes, we are. I think we are out now.
Yes.
Yes, it's slowly moving down.
Yes, totally out now.
So if you look at the endoscopic view of the normal endoscope, we have it outside. So I think it's
Yes.
good. Now we can leave it. افتحي.
Very nice.
Yeah, very cool.
So I think this helped a lot, this poor lady, because really she would have suffered terribly with this stent in place, especially that we do have a prolonged survival expected for this lady. She has a benign tumor, remember? So it was really essential to get this out and really save her from surgery. She's not a good surgical candidate. I think we'll remove the stent and try to have another look inside, just to make sure that the rest of the bile ducts are are free, that there's no affection in the internal bile ducts. Although from what I saw so far, it doesn't seem to be a major problem. ما تفكيش السباي. Okay.
Can you enlarge the endoscopic view, cholangioscopy view?
Yes, okay, I just removed temporarily the spy for a moment. I will just throw in a standard forceps to remove this plastic stent.
Snare or forceps?
Snare or a snare.
Okay.
Open. Close.
Maybe we can go back to the endoscopy image.
صورة المنظار.
Okay, Dr. Hany,
Yes.
could you please to summarize the trick to use this kind of the technique?
To introduce the spy, you're saying?
Summarize the tips for the technique.
Yes. So basically, of course, the introduction of the spy. Usually, it is much easier if you do it on a guide wire, but in this case, it was much facilitated with the presence of the metallic stent. So it is not essential to have it over a guide wire, but you can.
So this summarizes the importance of SPY in such a clinical situation. We have patient which is poor surgical candidate, we have no other solution, we have migrated impacted stent, so the patient carry higher risk of cholangitis, and as we see we have totally obstructive plastic stent. So I think the SPY in this case saved the patient from recurrent infections or cholangitis for the next time.
So as you can see now, we're going in on the spy view. We're going inside the metallic stent. Now we've passed the stent. Now what I see here is normal lining of the common bile duct. Screen.
We are just checking no other abnormalities inside the biliary tree, checking no perforations or other suspected areas, and as we see we have normal total lining of the common bile duct. I think also it's clear in the cholangiogram if we have the fluoroscopic view.
So now I think we're at the hilum.
Yes, we are near the hilum, I think.
Here we're at the bifurcation.
I think this is the site of previous impaction of the plastic stent at the left side.
Yeah. So yeah, this here on the left you just see, I think this is the site of impaction.
Yes.
It doesn't seem to be abnormal tissue. I think it's just hyperplastic. I think this is an area that I think we all still need to learn a little bit how to differentiate the visual image of a tumor versus hyperplasia or the effect of the impaction of the stent. I think here it's a
Do you do
bit.
biopsy? Do you do biopsy?
I think we can do biopsy, yes. We can do a SpyBite, although I highly doubt that it's anything other than the compression of the stent that did this image right here. But I think, yes, we can take a biopsy just to confirm that there is no affection in the upper bile ducts. But other than that, I think we're fine, and I think we did this lady a good job. Can I have a SpyBite, please?
I think also the cholangiscopic view we have is only inflammatory changes, and we have no obvious suspicious area for malignancy.
There have been several studies or trials, I mean, by several groups. I think two main groups tried to put the visual criteria for defining the differentiating malignant from benign lesions using the cholangiscopic view. But I think so far the results are not really good. There is no proper inter-observer agreement as good as we would like. Yes, there have been some signs, like for example the presence of ulceration, the presence of abnormal vessel that points strongly to malignancy, but still I think we are still far from having a confident diagnosis using just the cholangiscopic view.
Yes, but I think the most important point is abnormal vessels. I think this is the most important for highlighting dysplasia or suspected malignancy.
Yes?
The question from the participant is what your idea or the technique? You use a traditional endoscopic removal first, or decided to use SPY for the standardization?
I'm not sure. Sorry, I got your question. Can you say again, please?
The question from the participant, is it more effective to use SPY or the conventional balloon removal?
Open.
Okay. In the daily routine, it's not applicable to use the SPY in daily routine. So we reserve SpyGlass for special situations. Like this patient, as you can see, the stent was little bit impacted inside the wall of the common bile duct. So the traditional method, which usually succeed, failed in this case. Despite trial biopsy, trial balloon disimpaction, all methods failed, and this is why was explained by the SPY, because it was impacted. So at this moment, we have no other solution. So SPY is not for the daily or everyday use, but it's for special situation like this one. I think so.
Yes, thank you very much.
You're welcome.
Yes. Yeah, we have to remember, of course, that the cost is a bit prohibitive sometimes. So yes, we limit it to only the specific cases when we fail to extract using the standard methods.
Yes, this is a technique to rescue if you cannot use a conventional technique, right?
Yeah.
Yes, and actually it rescues the patient, because it's not easy to do surgery for such patient, and the patient was probably may have recurrent cholangitis. We have impacted and totally obstructed the stent, which may carry risk of recurrent cholangitis. So I think we did a good job for this patient by saving her from unnecessary surgery or recurrent cholangitis, I mean.
Yes.
We just, after checking, we can, after this SpyBite, we just to assure no suspicious area at this moment. At this part, we can see that this part is mostly the part of impacted stent, but we take SpyBite just to assure no other pathology or double pathology in the common bile duct. And by this, we finish our procedure after checking most of the common bile duct and checking no other suspicious area inside the common bile duct.
So you can see it's lovely to be able to target your biopsies like that. It's a very useful technique.
Could you explain the technique how to insert the SpyBite inside? Sometimes some resistant cannot move.
Yeah. It's a very good point. Yes, actually, these little things, they can make the procedure very difficult. Actually, so an important tip. Then of course you have to, the SpyBite, it's extremely thin and fragile, okay, so you really have to hold it very close to the insertion channel. May I have the camera? Yeah, the camera's on my hand. So as you can see, I'm holding it, I don't let my hand go far, so because if you push from far away, or you push quickly like you do with a standard catheter, you risk bending this the SpyBite. So always keep your hand very close to the channel and you insert very, very slowly. And other important point is that if your spy scope is really angulated, okay, especially at the exit from the endoscope, is that you find very hard resistance in pushing the catheter inside the SpyBite. So what you do in this case is that you really try to remove all the right knob that you have put on the endoscope. You try to straighten it, and you can even get the SpyBite outside completely and push the SpyBite to the end of the spyglass, and then you push it inside again.
Okay, the last point also to notice is dealing with the specimen of the SpyBite, because we have a very usually, if you can focus on my biopsy, we have usually a very little opening and we have a very little specimen. So this specimen not always deal with the specimen in formalin, because sometimes it is very small. So the most important also trick is to do a pathology print. We have cytology print. Just to take one specimen without putting in on formalin, you just make it on a slide, like doing cytology, like doing FNA, just to make a print, to make it easier to give cytological impression, just not depending on pathology on very small snips. So it's important to take one part of the specimen and do a pathology or cytology print for this one.
How many buy you recommend? How many buy?
Usually, if we're really suspecting malignancy, the minimum that you take is 3. There has been a nice study, I think, from Florida, where they showed that going beyond 3 doesn't help in adding into the outcome or yield of the biopsy. So I think 3 is really the magical number, and of course 3 that you are happy with, 3 that you really feel that they have actually got the target that you want.
If you can come close to the pathology, we did a one print. Yes, we did a one print. If it's clear, if you can zoom, we did one print for the last SpyBite. This is a small print on a slide, which is easier to examine for the pathologist. It's like cytological examination, which is very important. We will take 2 snips in formalin and 1 snip, which is this print. We called it cytology print.
Very nice.
Application from Misr from Florida recommend if you on-site cyto, you get more yield, right?
Yes, if we have on-site cytopathologist, it's very important. Just with the print, we can have initial diagnosis within 5 minutes maybe. So this is important part, and the endoscopy units having on-site cytopathologist, usually it's very important to check, especially these precious biopsy samples. Maybe it's not that important now for US because we have FMB, but still for the SpyBite we have a small snip, so it's important to check. At least you have adequate tissue, you have both formalin cell block, and you can have also cytology print to increase the diagnostic yield of this precious technique.
Sabra?
You have a SpyBite net. Do you use SpyBite or SpyBite net?
No, yeah, this is the SpyBite. We still don't have the privilege of using the SpyBite Max,
okay.
But we're really excited for it because it was actually a problem always, yeah, the size of the biopsy. But I hope the SpyBite Max will solve this problem. Sabra? So now I'll just do a cholangiogram to finish and to make sure that everything is fine. So
this was my question. Do you always repeat a cholangiogram or cholangioscopy may be enough
screen
for the final diagnosis?
I don't know, I'm a bit maybe too classical or traditional. I like when I go inside to do a cholangiogram, because remember, however you go inside with a SpyBite, there are areas that you will not see, that will only be seen by a proper cholangiogram. Screen?
I fully agree. I think it was
Yes,
our audience.
I think we finished our case and we have to move to the third case in another room doing poem, and we hope we did a good job. Thank
Okay.
you.
Congratulations.
Thank you.
Thank you.
Thank you.